Testosterone therapy is replacing your own natural production with exogenous testosterone. What that means is you're getting it from the outside. And there's different ways that you can get testosterone. I typically use a cream or injection to get consistent, stable levels that we can adjust if needed. Who can benefit from testosterone replacement therapy? Typically individuals who are struggling with chronic fatigue, low motivation, if they've noticed a decline in libido or overall erectile quality, if you're depositing more fat in your midsection, if you are making attempts to go to the gym and you have poor recovery, you're not building muscle like you used to, those may be signs of low testosterone and worth being evaluated for.
Cool. Who can benefit from it?
Everyone, or
Who can benefit from testosterone? Testosterone naturally decreases by about 1% a year after the age of 30. And so those are typically later, older, middle-aged, 30, 40, 50-year-old guys are the ones who struggle with it the most. You hear about menopause a lot with females losing their hormones. Guys go through what's called andropause, where naturally circulating androgens decline with age. That does not mean younger people do not need testosterone replacement, because we have uncovered that there does seem to be a lot more endocrine disrupting chemicals these days. And I do see 20-year-olds, young 30-year-olds with low testosterone levels. And it's much more common than I thought it would be. We uncover it quite a bit these days. Those are also individuals that would benefit from testosterone replacement therapy.
Are there obvious or consistent
signs
that you could
Signs that you could be low on testosterone are mainly subjective. If you just kind of lost that drive that you used to have, you have low motivation, just chronically fatigued to where you can still get your job done, but at the end of the day, you're just collapsing, melting into the couch. Where you used to be busy doing things in the afternoon, you're less interactive with your wife and kids. Those may be signs that your testosterone is decreasing. It does not always mean it's a low testosterone. We will look for other factors that could be contributing. One, from a lab standpoint, but two, life these days is just difficult and tough and always high stress. And so sometimes it's lifestyle factors that we look at. Are you getting enough sleep every night? How is your work-life balance? How's your relationship status? How's your current mental health? Do you have an exercise regimen that can help with all these? So there are various other things that we will look into just to make sure it's not a low testosterone issue specifically, but typical signs of low testosterone are just kind of fit that narrative of low energy, poor motivation. If you've noticed a decline in libido or erectile quality, that can be another sign. The decline sexually is not always a specific low testosterone issue, because that is also largely psychological. You can have low testosterone and still have good erectile quality and good libido. It's kind of nuanced in the fact that these are very broad symptoms. And so we do like to get a set of labs initially to cast a wide net to make sure we don't super focus on testosterone alone whenever something else may be contributing to your symptoms that needs to be looked into.
what's the most common reason people
come in and say, am I low on testosterone?
The most common reason people come in to even seek evaluation of their testosterone is typically energy or libido mediated, meaning like they just don't feel like they were 2 to 5 years ago in terms of their energy level. They have increased brain fog. They can't seem to get their tasks done in the day like they used to. Sometimes their energy levels are good, but they've noticed a decline in libido and erectile quality. And a lot of times testosterone is associated with the sexual part more than the energy part. Testosterone is tolerated pretty well for the most part. Potential risks that could occur: hair loss and thinning, it can accelerate it if you're genetically prone. Acne can be a problem for some. Testicular atrophy happens in about 30% of guys. Secondary erythrocytosis is the fancy word for increase in red blood cells. That can be a problem. Prostate cancer and worsening cardiovascular outcomes used to be a negative of starting testosterone replacement therapy, but Current research seems to be disproving a lot of that and seems to be going the other way, in that it seems to be protective to your heart and prostate. A typical younger 20-year-old has high levels, 800 to 1,000, they feel great, not really have many side effects. With the age-related decline and exposure to endocrine disrupting chemicals, the levels have declined, and we just get you back up to those previous levels that you were functioning great at. So a lot of times there's little to no side effects. So let's expand upon those. There can be hair loss and thinning if you're genetically prone. It's not going to make your hair fall out if your hair wasn't going to fall out. But if your dad was bald at 50 and you're thinning in your mid 30s, it may accelerate it to where you lose your hair at 45 or so. We can talk about mitigation with hair loss. It is largely genetic based, and so it's hard to keep if at the end of the day you're going to lose your hair. But sometimes we'll do topical minoxidil. PRP is really good at keeping those hair follicles and offsetting as much as we can. If you're not willing to give up your hair, you can consider going to Turkey for a hair transplant. It's typically more cost effective than anything here, and they do a good job. But a lot of times guys will just accept that they're going to be bald and own it and start shaving their head and styling in that regard. I don't like finasteride or Propecia. That used to be used a lot to prevent hair loss, and I do not use that in the practice. There's a lot of side effects that I don't like about it, and that could be a whole different topic in itself. Acne is another side effect that can happen on testosterone replacement. We can change dose or frequency, and sometimes that helps offset it a little bit. We can change carrier oils because sometimes that makes a difference on the acne. And the acne with testosterone is typically chest and back. It's typically hormonal to where it's not on your face or anything. Diet can worsen acne if you have a diet high in dairy, sugar, gluten, anything that's kind of inflammatory. It may show itself as acne. Cleaning up the diet a little bit will also help hopefully limit and prevent acne outbreaks. If we need to move on with medications, we do at times, various creams, benzoyl peroxide's real good. You can get over the counter, or we can do prescriptions to help if it gets too severe, but also changing dose and frequency is another option. Testicular atrophy is another side effect that can happen. What that means is your testicles get smaller in about 30% of guys. It doesn't change penis size or anything like that. It's just testicles get smaller as they're not having to make it anymore. Once you're getting testosterone exogenously, meaning from the outside through cream, injection, pellet, whatever, your body's not going to make it on the inside. It realizes it has enough, and it's not going to keep pumping things out if it doesn't need to. Does that mean you need to be on it lifelong? No, in the sense that you can come off of it. If we start you on testosterone and you're not getting the symptom resolution that you're looking for, you can come off and your body doesn't just forget how to make it. It will land about where it was naturally, and that can take anywhere from 6 weeks to 6 months. We can give medications like HCG or SERM to help that be rebounded quicker to wake up the hypothalamus, pituitary, testicular axis. If you don't do anything, it'll take about 6 weeks to 6 months. You'll land about where you were previously with age-related decline. The other side effect that we monitor closely is that testosterone does make you produce more red blood cells. We'll check your labs to make sure your blood's not getting too thick. If it gets too thick, the normal treatment is to recommend therapeutic phlebotomy, which is the fancy word for blood donation. I'm not a super stickler on that, as it's kind of a controversial thing. Testosterone replacement in polycythemia vera, increased hematocrits result in increased strokes, heart attacks, and blood clots. In testosterone replacement, it does not follow the same mechanism as polycythemia, mainly in the fact that there's no platelet dysfunction. There's not been shown to be an increase in strokes, heart attacks, blood clots, DVTs, that kind of stuff with the elevated levels of hematocrit in testosterone replacement therapy. That doesn't mean that we don't have to monitor it. We still need to monitor it, because what I have uncovered a lot is if a guy's blood is getting more thick than what I expect, I'm going to get a sleep study to make sure you don't have sleep apnea. We've uncovered a lot of sleep apnea in guys. Other things that can cause an elevation in hematocrit is if you're a smoker. I don't like to treat guys who smoke with testosterone anyways. If you live at altitude, hematocrits at baseline can be in the upper 50s, low 60s their entire life, and they don't have an increased risk of strokes and heart attacks. And that's kind of the similar physiology with testosterone. But if we're monitoring and our blood looks super thick, we need to at least have a talk to make sure you're well hydrated, you're not smoking, and we don't need to get a sleep study on you. There was a thought that testosterone caused prostate cancer, or if you had an underlying prostate cancer, would significantly worsen it. We have had tons of literature come out over the last decade to show that that does not seem to be the case at all. Dr. Morgentaler is a urologist at Harvard and has been monitoring this since the 90s and has been the pioneer and help us be a little bit more comfortable in regards to testosterone replacement and prostate cancer. There's the thought that there's a prostate saturation model that once your testosterone level gets above 200 or 250, that you are not at an increased risk of prostate cancer as it's completely saturated. More testosterone isn't going to cause the prostate to soak up any more than the 200 to 250. And that's a pretty low number for most guys anyways. And if it's already saturated, then there's no increased risks. He is also even guys with active prostate cancer, putting guys on testosterone and doing active surveillance while they're on testosterone. All this to say is that it really seems that we're getting out of that kind of fear that it had anything to do with worsening prostate health or increasing risk of prostate cancer. And the last thing is heart health and overall cardiovascular outcomes. This also seems to be going the opposite way, that appropriately managed testosterone replacement seems to be cardioprotective. Low testosterone itself is an independent risk factor for worsening cardiac disease. So replacing testosterone seems to be beneficial and protective, especially if it gets that guy out moving more, an exercise regimen, feel better day to day. That's going to have better cardiac outcomes than a guy who stays at a testosterone level of 200 and feels too tired, too bad to get up and do anything or start any significant exercise regimen. Who doesn't need testosterone? For the most part, I think every guy can benefit from an optimal testosterone level. People who I wouldn't immediately start testosterone on are typically younger guys who are still working on building a family. I don't like to start testosterone in smokers. I don't like to start testosterone in anybody that has any type of active prostate cancer workup going on. Like I had mentioned previously, Dr. Morgentaler will start testosterone with somebody with prostate cancer, but he's a specialist. I'll reserve testosterone management to the specialist who's either actively treating their prostate cancer or doing the workup for prostate cancer. And the same with any history of coagulopathy, like blood clots, a blood clot in your leg or lung. I don't want to start or initiate testosterone therapy until that workup has been completed and we know why you got the blood clot to begin with. And then if you are stable with that, then maybe we can talk about it. I do not think testosterone is thromboembolic itself, meaning that it would cause another blood clot, but it is worth discussing with your hematologist and getting the appropriate workup prior to starting testosterone with a history of blood clots. So younger guys, why would I not want to start testosterone in a guy who is still actively building a family? As soon as you get testosterone on the outside, your body's not going to make its own testosterone. Your pituitary is going to stop sending signals to your testicles, luteinizing hormone, follicle stimulating hormone, and that's what makes testosterone and sperm. It stops sending both of those, so it's not only not making its own testosterone, it's not making sperm anymore. You're essentially infertile while you're on testosterone replacement therapy. Does that mean you should use it as birth control? No. The kind of joke in the TRT community is, what do you call the guy who uses testosterone replacement as birth control? Dad. It's just kind of a joke to drive home that it's not a great birth control, or we would all be on it for birth control. But I don't want to withhold it from a guy who is suffering, who can't get through the normal activities that he was. So what would I do in this regard? I typically recommend a sperm analysis and bank that sperm prior to starting testosterone, because if you have low testosterone, you may have poor sperm counts, poor motility anyways. I don't want to start testosterone and then we think the poor sperm count and motility is from the testosterone when that was there at baseline. So I want a baseline evaluation to see what we're working with. And then if you have a good sperm count and everything, then we're going to bank that sperm for future if needed. If we do have any problems with conceiving in the future because we started testosterone. And it's not a bad idea for a young guy to bank sperm anyways. It kind of provides you some insurance if you get a bad testicular injury or brain injury that makes you infertile in a couple of years, you could have that to bank on anyways. So then we have started you on testosterone and now your sperm count's 0. What do we need to do to manage this to make sure we retain your fertility? HCG is a medication we can add on to that, and that will keep your testicles awake. HCG mimics luteinizing hormone, and that is what tells your testicles to make testosterone, but intratesticular luteinizing hormone also provides some stimulation to the Sertoli cells, which are the cells that make sperm. And so you should still be making some sperm while on HCG. And you can run HCG continuously, even if you're not trying to conceive, so that your testicles never shut down completely. But I don't think it's necessary. And if you're actively trying to conceive, we can just bring HCG in at that time. Or we could do it 3 months out of the year just to wake your testicles up at that time. If child rearing is not for several years down the road, we may still bring HCG in 3 months out of the year just to kind of wake them up here and there. While you're actively trying to conceive, we can keep testosterone going. We just add the HCG. If that's not effective, sometimes I'll add FSH, which is the analog of the follicle stimulating hormone to get more sperm production. Most of the time, that is what results in conception. And then we can drop off the HCG and FSH and then just continue on normal testosterone replacement. Why don't I start testosterone on somebody that is smoking? There's a couple reasons. One, I do not think testosterone is thromboembolic. However, we know that smoking is thromboembolic, meaning increased chance for blood clots, whether it be in your legs, your lungs. Smoking absolutely does that. And I don't want it to be coupled with testosterone to amplify those effects. Honestly, it's a lawyer thing, because if you get a blood clot because you smoke and you happen to be on testosterone, I don't want to be the one blamed for it. Additionally, we're trying to change lifestyles for overall longevity. Smoking is in no way conducive to longevity, and I will work with you on stopping smoking. We can try medications. There's a few that work well. Sometimes being miserable from low testosterone is enough of an incentive to make the change to stop smoking. What is HCG? HCG is actually the female pregnancy hormone, and so it sounds pretty crazy to be put in the male body. HCG stands for human chorionic gonadotropin, and it mimics luteinizing hormone in the body. So it's an injectable, and you inject it 2 to 3 times a week, and it mimics luteinizing hormone, which means it's sending the signal to your testicles to make testosterone. So what is HCG used for in testosterone management? It has a few different options. One, I will use it if you're on testosterone or steroids and trying to come off of them to wake your testicles back up, because it will send more signal to keep them awake. If you're worried about your testicle size while on testosterone, it helps retain testicular volume. And so if that becomes an issue cosmetically for you, we can start HCG, and that typically helps restore testicular volume. If you want to retain fertility while you're on testosterone, HCG is the best at keeping viable sperm counts and preventing complete testicular shutdown while on testosterone replacement therapy. HCG can be suppressive if used as monotherapy. So meaning if we use HCG alone to try and get better testosterone levels without starting testosterone replacement therapy, it can improve natural levels. However, it's kind of the same as starting testosterone, as your body is going to realize it has enough of that signal, and it's going to stop both LH and FSH signal from your pituitary to your testicles. So we do need to add a SERM in the background, and so that can keep the pituitary testicular axis awake at the same time. SERMs are selective estrogen receptor modulators. They trick your brain into thinking that you're estrogen deprived. Guys don't have an estrogen producing organ. So the way the body thinks what we need to do if we're estrogen deprived, it sends more signal from your pituitary, FSH and LH to your testicles to make more testosterone in sperm. But the testosterone is then converted into estrogen via aromatase, an enzyme, and makes estrogen. So it's kind of, that's your body's way in a guy on getting higher estrogen levels. Examples of SERMs are Clomid, which is clomiphene, and clomiphene is another one. Tamoxifen or Novadex are all different types of SERMs that you may have heard of in the past, and they can be used as monotherapy. Occasionally, we will try clomiphene or tamoxifen as monotherapy to increase your testosterone levels, especially in a younger guy. If you still have adequate testicular function and it sends more signal to your testicles, you may get a higher testosterone level. With the higher testosterone levels from SERM therapy, sometimes we don't actually get a clinical response, meaning that even though you have a higher number on paper, we don't see symptom resolution every time. If your testosterone level is 250, we put you on clomiphene or tamoxifen, and now it is 750. A lot of times you don't feel like you have a 750 of testosterone. I want to say it doesn't happen, and sometimes it does, and that does buy us some time. I don't like for a guy to be on a SERM chronically as quote unquote their TRT. You just don't get quite the same effects. If you're deficient on testosterone, the best way to fix low testosterone is with testosterone. However, this does buy us some time if you're still actively building a family or just not willing, or if you're not wanting to make the commitment of testosterone replacement with injections or creams. So HCG and SERM therapy is something that I'll use at times for younger guys who were just trying to buy some time until they build a family or are done building their family. It does not shut down your natural production, and so we don't have to worry about any type of fertility. And we do get good symptom relief in some guys, not all guys, but I have had guys get levels over 1,000 on the HCG and SERM combination, and they feel great and they didn't even need testosterone. Additionally, sometimes we'll do it for 3 months, and sometimes you can get 6 to 8, 12 months out of it. And that, again, just buys us more time without sacrificing your fertility of jumping straight into testosterone.